Hey everyone, and welcome to this Clinical Explainer. Today, we're diving into an absolutely crucial skill for your OSCEs and clinical rotations, mastering breast palpation. Whether you're demonstrating this technique on a mannequin, for an exam setting, or working with a real patient, having a precise, systematic approach is it's vital. So get ready to take some mental notes as we break down the definitive clinical standards.
So here's the big question. How do you accurately palpate a breast for swellings? It sounds straightforward, right? But the answer requires real precision. We aren't just feeling around aimlessly. We need to strictly follow NMC guidelines for physical examination to ensure absolutely nothing is missed and that every single finding is contextualized properly. Let's look step by step at exactly how to pull this off.
All right, here is our clinical checklist for today. Phase 1, the triple assessment context. Phase 2, breast anatomy basics. Phase 3, correct palpation technique. Phase 4, identifying breast lumps. And finally, Phase 5, next steps in diagnosis.
Okay, kicking things off with Phase 1, the triple assessment context.
Palpation doesn't just happen in a vacuum. It's actually step one of what breast surgeons universally call the triple assessment. Anytime a woman presents with symptomatic breast disease, we use this exact systematic approach. It combines a clinical breast exam, so your inspection and palpation, with radiological imaging like an ultrasound or a mammogram, and finally tissue sampling, which means cytology or histology. And honestly, what's really amazing about this triad is its efficacy. When you combine all three, the positive predictive value and diagnostic accuracy is virtually 100%. Literally. So if you nail the clinical exam, you are setting up the rest of this diagnostic pathway for absolute success.
Let's move on to Phase 2. Breast anatomy basics. Before we even think about palpating, we've got to intimately know the structures we're touching, right? Anatomically speaking, the adult female breast sits over the pectoral region. It extends from the second rib up top all the way down to the sixth rib, or the inframammary crease. Medially, it hits the lateral border of the sternum, and laterally it goes out to the mid-axillary line. But here is the absolute most crucial detail for palpation. Deep to the breast is the retromammary bursa, or space, which is full of loose areola tissue. This space separates the deep layer of superficial fascia from the pectoral deep fascia, and it's what allows the breast to move freely. You've got to know what this normal mobility feels like, because if you find a lump that restricts this movement, that is a massive red flag.
All right, Phase 3, correct palpation technique.
So this is where your clinical skills are really put to the test. First things first, your physical setup. You always want to examine both breasts, and the ideal setup is having the patient in a supine position, completely lying down. You've got to have the patient's arm raised on the side you're examining, and ideally, place a mattress support or pillow right behind their shoulder. This evenly distributes the breast tissue over the chest wall. From there, you're going to systematically use your fingers over all 4 quadrants of the breast.
Now, when you're actually palpating, please don't just poke with your fingertips. You need to use the flat, sensitive pads of your middle 3 fingers. And to make sure you don't miss even a single centimeter of tissue, use the dial of a clock method. It's kind of like a giant puzzle. You just work your way systematically around the breast, imagining a clock face. You move from the outer edges toward the nipple, or vice versa, making these overlapping circles or radial lines. That's how you guarantee a truly comprehensive exam.
Oh, and quick side note here, but it's super important. You are treating a human being, not just a plastic mannequin. The guidelines explicitly highlight a vital piece of bedside manner. Remind the patient that 90% of breast lumps are not cancer. Having a breast exam can be incredibly anxiety-inducing, right? So offering that factual reassurance while you're executing your technique is a standard foundational part of professional clinical care.
Let's get into Phase 4, identifying breast lumps.
So your technique is locked in. But what exactly are your fingers feeling? Let's talk pathology. If you feel a firm or solid mass that is highly mobile, sometimes this is called a breast mouse because it literally just slips right away from your fingers, you're most likely looking at a fibroadenoma. Now, if the lump feels soft, fluctuant, and really localized, that's frequently a benign cyst. But if those finger pads detect a hard mass that feels fixed to the surrounding tissue or the muscle underneath, that is a classic hallmark of a carcinoma.
Age and specific presentation play a huge role here too. For example, fibroadenomas fall under ANDI, which stands for aberrations of normal development and involution. These are the most common benign tumors in young females, usually between the ages of 15 and 25. Cysts, on the other hand, present a bit differently. Estrogen-dependent conditions can lead to a well-localized, fluctuant swelling known as a blue dome cyst of Bloodgood, Or if you're feeling multiple, diffuse, small cysts, you might actually be palpating Schimmelbusch's disease. Distinguishing these benign conditions from malignancy is absolutely key.
But what happens when the disease is more advanced, like an advanced carcinoma involving the right breast with ulceration? The primary diagnostic factor you're looking for here is fixation. Remember that retromammary space we literally just talked about? Well, during palpation, you have to test if the mass is spread into those deeper planes. If the lump is fixed to the pectoralis major muscle, you'll actually note restricted mobility when the patient contracts that muscle. And if it's invaded the chest wall itself, the breast won't fall forward when the patient leans forward, and it won't move up when the arm is raised. Your fingers and your eyes are assessing for exactly that loss of mobility.
Finally, let's look at Phase 5, next steps in diagnosis.
Okay, so your palpation found a lump. That means we have to complete the triple assessment with imaging. Now, a benign cyst is going to appear anechoic on an ultrasound, meaning it shows up black on the scan, looking like a nice, oval, well-circumscribed shape. A carcinoma, however, it presents as the total opposite. It's irregular, non-compressible, and it usually has this taller-than-wide vertical growth pattern with posterior acoustic shadowing. It's fascinating because what you felt with your hands, a soft fluctuant mass versus a hard, fixed one, is perfectly mirrored right there in the radiological findings.
So the crucial point in wrapping up the triple assessment is using that imaging to guide your tissue sampling. That could be a simple aspiration of a cyst, an FNAC, fine needle aspiration cytology, using a standard 23-gauge needle, or a stereotactic core needle biopsy for a solid mass. But here's the thing. The exact coordinates of the lump that you first felt with the pads of those 3 fingers, that is what dictates this final, definitive step. Combining your meticulous clinical exam with the imaging and biopsy is exactly how we guarantee that 100% diagnostic accuracy. We've covered the complete clinical arc today, from the anatomy and the exact positioning of your fingers to spotting benign versus malignant lumps and finalizing everything through the triple assessment. So I'll leave you with this thought. How are you going to integrate this precise, step-by-step palpation technique into your very next clinical rotation or OSCE? Because honestly, mastering this physical skill isn't just about passing an exam. It is the absolute bedrock of accurate patient diagnosis. Thanks so much for joining me for this explainer, and definitely keep practicing those clinical skills.